I'm Dr. Stacy Loeb from NYU, and we've just hosted the prostate cancer treatment panel. The first study was presented by Dr. Cooperberg, comparing different types of treatment options for prostate cancer, because really we don't know exactly what is the best kind of treatment. So in his data set, he showed that for all comers, prostatectomy had the lowest rate of prostate cancer death. But if you just look in the low-risk group of patients, there was no difference between any of the treatments or active surveillance/watchful waiting. So his conclusion was basically that surgery does appear to be a great option as a first treatment for high-risk disease, and at least in this non-randomized data, reduces the risk of prostate cancer death. But for low-risk disease, active surveillance is safe and should be encouraged. The next study was by Dr. Stein, looking at patterns of prostate cancer diagnosis by age. He showed that older men are more likely to be diagnosed with aggressive prostate cancer, and a greater proportion of them died from prostate cancer compared to younger men. This agrees with other studies suggesting the same, that older men are more likely to be diagnosed with high-risk disease. The next study from our group, including Professor Staten from Sweden, who's the lead author on the study, looked at patients in their 70s diagnosed with high-risk prostate cancer. These are the same type of patients in Dr. Stein's study, where these older men were being diagnosed with high-risk disease, but Professor Staten's study showed that many of them were not receiving curative treatment for their prostate cancer. This may be an unintended consequence of all of the debate about over-treatment, where we now may be actually undertreating healthy men in the 70s who have high-risk disease. Professor Staten's presentation showed that healthy men in the 70s with high-risk prostate cancer are most likely to die of prostate cancer. 20% of them die from prostate cancer at 10 years without treatment, and that was a higher cause of death than cardiovascular disease or any other disease. So why are so few of them actually getting curative treatment for a disease that will kill them? This highlights the need for better estimation of life expectancy so that we can make appropriate treatment decisions. We heard from Dr. Fontenot from the University of Kansas, who did a unique study looking at all of the men in their registry with metastatic prostate cancer, looking backwards to see how much screening did they have and could this have potentially been prevented. They found that only 13% of the men with metastatic disease had a PSA test before age 55. So this is just not enough. This is too few and too late. So we do need to alert young men that a baseline PSA measurement at a young age is the best way to assess the risk of developing life-threatening prostate cancer. This study is unique by looking directly at the men with metastatic disease to see their patterns of PSA testing. And it does agree with other studies looking forward. There's a nice model from Dr. Etzione's group projecting that if we discontinue screening, as suggested by the Preventive Services Task Force, that metastatic cases will double by 2025. So putting all of this together suggests, number one, that we do need to be more careful about selection for prostate cancer screening, and that screening needs to be focused on young, healthy men who should be offered a baseline test to assess their risk of life-threatening prostate cancer and to find those life-threatening patients in time for cure. On the flip side, older men are more likely to be diagnosed with high-risk disease, and undertreatment of those men could cause an undue burden of prostate cancer death. So on the treatment side, we should be better about estimating life expectancy to help our patients make good decisions about treatment. This is the time where we are finally moving away from a one-size-fits-all approach to prostate cancer. In the past, everyone got PSA tests once a year was a common pattern, and men diagnosed with prostate cancer, the vast majority of them just were prompted directly to treatment. So there was a lot less attention paid to personalized risk assessment. We are now moving into the era of personalized medicine, where we can do a better job of selecting patients for both screening and treatment, taking into account multiple factors, including their general health status, to help them make a better choice for them as an individual. So there's really no reason anymore that we have to create vast rules for the whole population. Each man at a young age should be offered the opportunity for a baseline prostate cancer risk assessment with PSA, which tells them their risk of life-threatening disease during their lifetime. And for older men who are diagnosed with high-risk disease, they should be counseled about the potential side effects of treatment, but also the fact that they're at a great risk for prostate cancer death in the absence of treatment, to help them to just make a better decision for them.